Thank you, OncoAlert, for the chance to discuss the recently published paper on multimodal de-escalation strategies in early breast cancer, published in the ASCO educational book after the exciting session last ASCO in Chicago that I had the pleasure to lead together with Nadia Harbeck and Elizabeth Berger. The paper basically shows an overview that excellent cure, as shown in clinical trials, now represent an high bar in the attempt to de-escalate or optimize therapy for early stage breast cancer. However, any therapy de-escalation must be performed in the context of a multimodal treatment concept, as an optimization of one modality should not be met by the escalation of another. So, for example, in surgery, the omission of sentinel biopsy can be now safely offered for patients with low to intermediate hormone receptor positive and not only as negative disease. After neoadjuvant therapy, the adapting surgical and radiation therapy treatments towards systemic treatments response is really a current practice. However, technical quality assurance is really mandatory. And also the increased use of modern target agents also in early breast cancer require adaptation of radiotherapy timing that have been considered by recent consensus recommendations. And last but not least, the omission of chemotherapy is a key question for patients, their doctors, especially in hormone receptor positive to negative early breast cancer. In patients with the intermediate 1, 2, 3 involved nodes, the gene expression tools safely allow now chemotherapy omission in selected cases. It's really also important, and we pass through the endocrine response assessment that is basically based on a proliferative index determination, and it uses a tool of important information, especially in premenopausal patients. So basically, the overall goal of this overview and of the optimization of treatments is trying to reduce treatment burden without, of course, compromising patient outcomes. For instance, the optimization, the escalation concept overall, as well as the use of biomarkers in the future using therapy de-escalation, needs to be evidence-based, a level 1 evidence-based and validated by prospective clinical trials. So we want to basically summarize practical applications that we overview in this paper. Early breast cancer, multimodal treatment de-escalation is feasible without compromising outcomes, but need to be discussed in a context of multidisciplinary team. Hormone receptor positive to negative early breast cancer, sentinel node biopsy can be safely omitted in specific patients according to the NSEMA and SOUND trial results. We are going to overview all the most important trials. After neoadjuvant therapy, the mapping with dual tracer retrieval of sentinel nodes lower the false negative rate of sentinel node biopsy below 10%. After neoadjuvant therapy, primary systemic therapy, radiation therapy might be minimized or tailored in an individual patient cases if systemic therapy is achieved in terms of excellent tumor control. In hormone receptor positive to negative breast cancer, in patients within 0 to 3 involved lymph nodes, the use of gene expression tools and endocrine response treatment might allow omission of chemotherapy in pre and post menopausal patients. These clinical implications are really important and set the stage for future direction, especially in the radiation therapy context, surgical context, and systemic therapy. But the way forward will require reliable data, integrating clinical, pathological, and molecular factors into a multifactorial frameworks guided by prospective trials, but most of all, multidisciplinary collaboration in order to optimize outcomes while balancing efficacy and toxicity.